All right, welcome everybody. Thanks so much for joining us today. So this is the March University of Calgary Women's Health Seminar Series. Today we have Dr. Lauren Walker joining us, so she's going to be doing a presentation for us shortly. But before we get started, I'm going to do a little bit of housekeeping and background. So I'd just like to do a territorial acknowledgement. So here at the University of Calgary, I'd like to take the opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, and this includes the Blackfoot Confederacy, comprising of the Siksika, the Piikani and Kainai First Nations, as well as the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The City of Calgary is also home to the Métis Nation of Alberta Region 3. So thanks so much for everybody for joining us today. So this is a pretty informal seminar, so please don't feel like you have to have your camera enabled except during the question and answer period at the end. So if you're asking a question, it is nice to see a face, but if you are in a situation where that's not going to work for you, don't worry about it. Please do keep yourself muted during the seminar. I will let you know I do have control over muting people, so if I hear noise, I may mute you. So if you suddenly find yourself muted, that's what's happened. And then finally, the question and answer period. Please raise your hand. So there's a little bit of a bar on the bottom where you can raise your hand on screen. Please do that. Or type your question into the chat box, or if you'd prefer to have your question asked anonymously, please feel free to just message me. So you can go into the chat box and direct message me, so Lauren Drogas, and I will ask your question for you. So finally, please note that the presentation portion of the webinar will be recorded and published on our Libin YouTube channel. Everybody who has registered will get a link to that hopefully later this week. But in order to have a more open question and answer session, that will not be recorded. Also, please be mindful that since we are discussing something today that has a little bit of a medical note to it, please be mindful of your own privacy and other people's privacy while asking questions. All right, and with that, I'm going to introduce Dr. Lauren Walker. So she's a registered psychologist in the province of Alberta. She is an Adjunct Associate Professor in the departments of Oncology and Psychology at the University of Calgary. And in 2019, she was recognized as one of Calgary's top 40 under 40 for her innovative work in developing programs for cancer patients to manage sexual side effects of treatment. She's written 50 peer-reviewed articles on psychosocial and sexual adaptation to cancer. Dr. Walker divides her time between sexuality research and her private clinical practice, where she counsels both individuals and couples experiencing sexual difficulties. So thank you so much, everybody, and join me in welcoming Dr. Walker for her talk today, Understanding Sexual Difficulty Among Women. So I'm going to pass my screen sharing over to Dr. Walker, and hopefully all is smooth.
Perfect. So thank you so much for the introduction. Are you able to confirm, Lauren, if we're in a good
You
presentation?
are on the right mode, so take it away, please.
You know, appreciate the opportunity to speak to you all today. I have lots of content. I feel like I could talk about this topic for days, so I will do my best to present what I think will probably be most useful, understanding we do have a diverse audience today. So there will be a few elements that are more geared perhaps to medical practitioners, but also, sexuality is something that is relevant for most people. And hopefully there will be some information here that could be even helpful for you as an individual. So thank you for attending today. To give you a bit of an idea about objectives and what I hope to cover, I'm going to review a little bit of the background on why sexuality tends to be so difficult to talk about, particularly in a medical setting. And I'll introduce a model that's very helpful for intervention and assessment of sexual concerns called the Plicit model. And I'll use that as a framework throughout the talk today. And we'll talk a little bit on how to get the conversation going, as that's sort of that first step. We'll review a bit about some common sexual health concerns and some information that can be used to provide to patients to help support them in this nature. I'll introduce just kind of an overview of what some of the strategies are that can be used for treatment, but won't go into too much depth with that. and then briefly discuss where and when you may choose to refer patients. So when talking about sexuality, we know that there are some limitations to how this is discussed in healthcare settings. So while 96% of healthcare professionals will say that it is part of their job to talk about sexuality with their patients, only 2% say that they make it a routine part of their care and ask about this part of care with all of their patients. And when we look at seeking help for sexual difficulties, 39% of women say that they would like to seek help for their problems related to sex, but only 6% had done so. So we have a challenge here in that many women do not reach out for support, and many healthcare providers do not make it a routine part of their assessment with their patients. So I am going to acknowledge that while this presentation is focused on women, and many of the stats in the presentation are focused on women, what we know about sexual response is that a lot of what I'm going to talk about today will be relevant for all genders, people with vulvas, so we're not necessarily making the assumption here that this is just about women's health. So when we look at what are some of those drawbacks, or why are people not having these conversations, I've kind of summarized these into a few key areas. Often there's this phenomenon of, no, you go first. There might be some embarrassment, whether that's on the part of the patient or the provider, that if you bring this topic up, it might make the other person uncomfortable, or just not even being sure how to bring the topic up. And with providers, there's often an assumption that it might be an invasive thing to ask patients about, that it would be invasive to their privacy. But what we know is that unless the provider asks, it's likely not a topic that's going to be brought up, unless you have a patient who's really quite comfortable and good at self-advocating. Another concern is that many providers would say it's kind of like opening Pandora's box. Maybe there's a lack of time in appointments. They're very limited anyway, with lots of content to cover. Many providers describe having inadequate expertise, so not having received very much training in sexual health and not knowing where to refer patients should they indicate that they do have a problem. Of course, something I've seen a lot within the cancer center and my work in cancer care is that often sexuality may be seen as less important. So overlooking sexuality while focusing on other acute problems, like obviously extending life and life-saving treatment is very, it makes sense that that would be priority, but also acknowledging that sometimes those treatments themselves can impact sexual function. So as I've mentioned, I've framed my talk today around the Plicit model, and you'll see from the date there that this model has been around forever and that it's still extremely helpful in terms of understanding how we can intervene and support patients. And so the model suggests that all providers can at least start by establishing an environment of permission for their patients, that it's okay to talk about sexuality with providers. And then at the next level, so in this tiered model, that we can also offer some limited information to support our patients. And I would hope that all providers can have some degree of limited information in their toolbox to be able to offer to patients. And then the next level would be more specific. So actually offering some suggestions for treatment, implementing and getting those started. And that may or may not be accessible to all providers. That would be more specific. And then at the top tier would be the intensive therapy. So those who are sex therapists or sexual health clinicians who would have specialist expertise in sexuality. So at the most basic level, again, I would say permission is something we should all be able to do as healthcare providers and just as human beings. We know that sexuality is often a taboo thing. It's difficult to talk about with our friends and family, but what if we started to change that? What if we started to say, you know what, this is an important topic and we should break down some of those barriers and taboo. And so with establishing permission, it's important to let patients know that we can talk about sex, we can ask questions, that it's okay to continue to be sexual. So for some patients, they may be dealing with a medical condition and they don't know whether they should or not be sexual. And for others, they may need permission to not be sexual. So maybe they're feeling too ill and they need to have that support to say, it's okay, you can actually take a break from being sexual. And maybe they need some support with partners around that as well. So those are some examples of what we're permitting. And why is permission needed? So if we don't ask about sexuality, patients and partners often suffer needlessly and they don't know where to ask for help. And they often erroneously think that it's not valid to be able to talk about sex, especially in a cancer setting. They may wonder, is this even something that I should be worried about or that I'm allowed to be worried about? Here I am, going through cancer treatment. But that the benefits of asking are far outweighing of the risks of not asking. So we can reduce stigma and isolation. We can give a voice to those who are suffering quietly. And we're increasing the awareness of impact in a broader sense as well by having these conversations. So even helping others. And then there's an opportunity to directly enhance quality of life and relationships. So how do we talk about sex? I'd like you, if you are a clinician, to reflect for a moment and think about what are some of the questions or the ways that you might introduce the topic of sexuality to your patients. And if you're not a clinician and you're maybe thinking about how would you talk about sex with a partner, or how would you talk about sex with a friend? And the responses obviously might be different, but I've created a few questions or sentence stems here that you can use if you are a clinician. I find that initiating discussion really has to be quite matter of fact, just acknowledging that this is an important thing. And so even maybe making the assumption that the impact of that a medical condition can impact someone's sexual life. So what impact has, cardiovascular disease or diabetes or motherhood or parenting or whatever, insert whatever that issue might be that you focus in, and say, what impact has that had on your sex life? So you're assuming that there probably has been an impact, and that might make people feel more comfortable to dive in. Another question is to just ask whether people have been experiencing any changes in sexual function. We know that function changes over the course of a lifetime with a variety of events that we experience. And so likely people are going to notice that something has evolved over the course of their lifetime. Another question would be more around someone's sense of sexual self. So do you feel any different about yourself as a woman, having been through fill in the blank, whatever that condition or event may be? And another one that I find is really helpful is to normalize that this is a common concern for people. So many people are concerned about how treatment will affect their sexuality. What concerns do you have? Or do you have any concerns? Is that something that you've thought about? So if I've ever been met with surprise from someone, oh, wow, that's not something I thought you were going to ask me about. When I explain that it's a common thing for people, and that if I don't ask, they may not know that it's okay to talk about. Everyone that I've ever talked to says, oh, okay, that makes sense why you're asking that. So if you're worried, what if I say it and my patient's uncomfortable? If you just explain that most people have some changes and that you're creating an environment where they know it's okay to talk to you, they're going to react well. So a couple of things when you're considering assessment and engaging with people is also to acknowledge diversity. So we know that our socialization about sex is extremely important. We have cultural expectations that may be helpful or unhelpful with regards to our sexuality. We have religious beliefs and practices that may dictate what's okay or not okay. Our upbringing, whether conversations were had in our households about sexuality, or whether we received any education about sexuality growing up. Perhaps it was entirely focused on avoiding STIs or pregnancy, or maybe abstinence only, or maybe we received no education at all. So acknowledging that there are likely to be lots of gaps in understanding. And then previous experiences. So again, acknowledging that if we've had uncomfortable, difficult experiences, non-consensual experiences, past trauma, painful experiences, that this is likely to influence our experience and sense of our sexuality today. So other factors as well, considering that sexuality is important for single folks, so not making the assumptions that we should just be asking patients with partners about their sexual function. Of course, considering diversity related to LGBTQ and all of our other categories. So acknowledging that people are going to have different experiences and values based on their identity, gender identity included in there, as well as folks who are asexual, that it still may be important to acknowledge sexuality as something that could be irrelevant or not. age, and then, as I mentioned, trauma history. So when you're considering all of these things, I think it's important. We as a medical profession tend to say kind of what's normal and what's a deviation from normal. But all of these are going to impact and dictate what is normal for the individual and what are their expectations about what they think they need to be doing. And so really acknowledging that each individual that you talk to, it's their individual characteristics and history that's likely going to dictate what's normal for them. So as we move beyond the environment of permission into limited information, I always find it helpful to start with some basics. So really looking at your basic anatomy. It's incredible how many people do not know the difference between a vulva and a vagina, that the vagina is the internal structure and that the vulva is the exterior genitals. Also, if you, some recent surveys have shown, I think almost half of people don't even know where to identify where the clitoris is. So having a basic instruction of what are these body parts so that when you have your discussions with them, you're referring to the same thing. If someone's having pain or discomfort and they describe it as vaginal pain, but in fact it's actually on their labia, then that's going to be a big difference in terms of your course of intervention. So I always start with basic anatomy. I think it's helpful to have a bit of a discussion around the role of estrogen in vaginal health, to normalize the experience of sexual difficulties, that these often occur throughout the lifespan and are associated with different events, and then to review some of the components of sexual response. So many of you are probably familiar with some of the signs and symptoms of estrogen deficiency, which can be associated with genitourinary syndrome of menopause. This list here is quite comprehensive, but I've actually added a few things to the list. So we know that there are lots of vaginal and vulval changes that can happen directly to tissues to make them less elastic and less moist, as well as other changes related to desire, difficulties with pain or discomfort or irritation of the vulva or vagina as well. And then, of course, some more urinary related symptoms, which can impact people's sense of sexual well-being and comfort. So I find it helpful to normalize and give a little bit of information about how common sexual concerns are. We know that sexual dysfunction becomes more common with age, as well as the longer we are in relationships. So if we consider perhaps reductions in sexual desire, which I'm going to actually challenge in our upcoming slides, but if we consider that to be a dysfunction, then we often see that increasing as couples are together for longer periods of time. As many as a third of women will report never having experienced spontaneous desire, and we'll differentiate between kinds of desire in our upcoming slides. 43% of women report having at least one sexual problem during their lifetime, and 22% of them report experiencing sexual distress about that problem. So again, a difference here between what might be happening on the functional level versus whether or not that's distressing to patients. And in the menopausal category, 40% of women report having symptoms of vulvovaginal atrophy, with fewer than 25% of them seeking help for those symptoms. So when women realize that there's 40% are experiencing signs, and again, this is of people reporting those symptoms, it's entirely possible that more women are having those symptoms but don't realize what they are, or even to know that those are things worthwhile reporting. The numbers are probably more like 1 in 2 or higher. Then when you're having these visits with your patients, to say half of women notice that there's a change, that it will help them feel more comfortable to talk about. As I mentioned, there's value in indicating some of the different areas of sexual response or sexual function. And I'm going to start with sort of where we started in understanding human sexual response. And then I'm going to show you where we've come. So how this has evolved or changed over time from our understanding from a medical and research perspective. So you'll see here that this is called the normal human sexual response cycle. This originated out of some work from Masters and Johnson who showed that there was some distinct phases in a sexual response. They actually brought participants into their laboratory, hooked them up to electrodes and monitoring systems, sat behind a mirror or a window and watched people engage in sexual activities. Now, if there's anything that is a deviation from normal, I would say that's probably it. That what they came up with from the study might not be the most representative of what most people experience. However, it was a really good place to start. They suggest that people start with desire or interest to be sexual. So that's in this left-hand part of the image here, that we start out with some interest, and that we move up in terms of arousal intensity over time, and that's a pretty linear process, at least according to this image, that we move to a place of readiness. So for people with vulvas, that would be sufficient blood flow to the vagina and expansion of the vaginal tissues, lubrication to be able to allow for penetrative activity. And for people with penises, this would be sufficient erectile firmness to be able to penetrate. That then people have an orgasm, and then they follow down to this period of resolution where the body comes back to its normal state, and of course are satisfied following their experience. So if we follow this, we can see that there are a few different domains of function. So when we look at those domains, we see desire, arousal, and orgasm. And these have typically been primary components of assessment of function. And you'll see these map onto the Female Sexual Function Index if you're looking at quantitative measurement. But two additional components that are really helpful to assess as well are experiences of pain. So whether there is pain related to sex or to sexual activity, and experiences of sexual satisfaction. So knowing that satisfaction as well, in addition to just whether your body is functioning adequately or not, is important. And then considering things like frequency, intensity, and changes over time amongst these categories. So I'd like to pause here for a moment and talk about diagnosing sexual dysfunction. So sexual dysfunction can only be diagnosed if there is both a functional impairment in one of those categories that we talked about, as well as an experience of sexual distress. So it's not enough to just say I have an erectile problem or I have a problem having orgasm or arousal. I also have to be distressed by that. So sexual distress is defined as the emotional experience that we have related to our sexuality. And that can include feelings of frustration, distress, worry, and anxiety. So there's been lots of good research done on sexual distress as a construct. And so I find it helpful to assess that directly. And this is a 5-item questionnaire, which is a reduced version of the sexual distress scale, validated now in use with women and men, and hopefully we'll be able to continue to validate that across the gender spectrum by the work from my research lab. So this scale asks how often has the following problem bothered you or caused you distress within the past month. And you'll see here that these items relate to distress, frustration, stress, worry, and sexual inadequacy. So you can use this scale, very brief. If you even had to reduce it down to 1 item, you could use the first item to assess how distressed someone is. And then you can consider sexual dysfunction as a diagnosis. If you are interested in measurement, looking at some of those other components, these are the names of a few scales that can be really helpful, and they're also very short. So the sexual distress scale, the short form is 5 items. The sexual satisfaction scale, which is the global measure of sexual satisfaction, is also a 5-item scale. And then there's a sexual function scale, which is great because there are 2 items that differentiate between arousal response based on anatomy. So one is asking about erectile function and one is asking about lubrication. And participants can choose which item would be best aligned with them, regardless of their gender. So you don't have to just use a male version or a female version. And then sexual adaptability. So this is the sex flex scale. which allows assessment for how flexible someone would be in the event that they were experiencing some difficulty related to sexual function. So I find that that one's really helpful in terms of assessing whether people are going to be open to altering their sexual practices in some way or engaging in treatment strategies. So if you're interested in research or assessment more quantitatively, there are some options for you. And then from a perspective that is not quantitative, I also find it really helpful to ask people about what their wishes or their expectations are for sex. So remembering that, you know, we may have a set of expectations for what we think we should be able to do that may or may not be realistic. And also knowing how do we assess or individually measure whether or not we think we're doing well or falling short in some way. So I also will remind you to not forget these things as well for the partner. I've had lots of people who are focused in women's health who just pay attention to things that are relevant for female bodies and who kind of forget that many women are having sex with men, and that often when one party has a sexual concern, there is also sexual difficulty in the partner. So, for example, if a woman is experiencing pain, her partner often experiences sexual difficulty as well because they're worried about the impact of engaging in sexual activities that they may hurt their partner. That could be associated with performance concerns, difficulty with erections, desire. So remembering that even though we're focused today on women's health, that these things are also really important for partners of all genders. So if you are a clinician and you're interested in making a diagnosis, I do want to highlight a few changes from the DSM-4 to the DSM-5, which is the Diagnostic and Statistical Manual that often we refer to when we're looking at sexual dysfunction. And so the DSM-4 differentiated between basically a low desire disorder, and then separated out arousal, so erectile function and arousal for females. And then if you look at related to orgasm, there's premature ejaculation or delayed ejaculation in men, and then orgasmic disorder for women. If you look at the condition here related to pain, it's called dyspareunia at the time and has been modified to genitopelvic pain or penetration disorder. But what is a big difference here is that these two categories related to desire and arousal have actually been merged in DSM-5 for women. So sexual arousal and interest disorder, that they often can co-occur, but that's a big distinction that has happened here. Now, that being said, there's a lot more common concerns that women often describe that are not necessarily accounted for by DSM diagnoses. So some common concerns include dryness or tightness of the vagina, pain related to intercourse, and I will acknowledge that there can also be pain related to external stimulation, so not necessarily penetrative activities, but there can also be pain and discomfort related to vulval health, as well as more pelvic pain. So we, of course, have complications related to pelvic health conditions. Folks with endometriosis, for example, or painful bladder syndrome will often describe pain related to intercourse, but not necessarily related to vaginal health. Loss of sexual sensation or changes in sexual sensation, or even ability to pay attention to sexual sensation, as well as desire and interest changes. And then what I tend to see a lot of is avoidance and fear related to low desire and related to pain. Of course, relationship concerns are also very prominent, and sometimes that's a bit of a chicken and the egg. Is there a relationship problem contributing to sexual problems, or is there a sexual problem causing relationship problems? So I'm briefly just going to put a bunch of options up here to consider things, contributors in your assessment. So other health conditions, medications, events like childbirth, transition to parenting, menopause. Mental health conditions, anxiety and depression commonly are associated with low desire, often one of the first side effects to, first things to disappear and one of the last things to come back, as well as medications can influence arousal and orgasm. Whether people are experiencing chronic pain more generally or pelvic pain, And incontinence, again, can be a big buzzkill when it comes to feeling yourself as a sexual person. That can be a damper on things. I did mention relationship factors already. History with current partners. So if there's been a long-standing conflict or even a script that couples tend to engage in when it comes to sexuality, there's a lot of expectations to unpack when trying to explore new ways of being sexual, as well as past relationships. Trauma history and sexual abuse are really important factors to consider, and body image or confidence, which obviously can change over the course of one's lifetime, as well as beliefs and values regarding sex. So I find this is probably one of the most rewarding areas that I like to focus on with clients, because we have a lot of assumptions about what we think we should be doing and what that should look like, and what is the best kind of sex, and what are our partners expecting of us. And those are very gendered, right? Those expectations are very embedded in our sociocultural conditioning related to femininity and masculinity. So that's also very important. So as I mentioned, we've got the normal sexual response, but I'm going to show you why it's not so normal. So for example, we see that a lot of folks do not exhibit desire or interest as a starting point for sex. They still may find themselves engaging in sex without a lot of desire. And that means that for some of them, desire might actually come once they start to become aroused. For others, desire and arousal may not extend in a very linear fashion. Maybe there's some enjoyment and some arousal, but it's not super high. For others, they may be multiple orgasmic. They may have a good steady increase in arousal and have several orgasms. For others, it's a less linear process when you're experiencing desire. There's an increase and then a decrease and an increase and a decrease. And again, it may not end once an orgasm has occurred or once sex is over. There may still continue to be some arousal and desire lingering. And lastly, let's call into question whether all participants are satisfied following their sexual encounters. So when we actually go out and present this model, in particular to women, but also to men, especially men with sexual difficulty, they say this linear thing doesn't work for me. There's a lot of deviations here. So in comes a fabulous model, which is the circular sexual response model. I am not going to explain this in detail, as I find it usually takes me about 15 minutes to explain this model. So if this is on the recording, or you can go back and take a look at it when this is on posted, but this video here is actually a 15-minute video of me explaining the whole model. So feel free to go check it out if you want the whole explanation. But what we're suggesting here in this model is that we actually start not with desire, but with motivation to be sexual. And that could be because you feel some desire, or it could be an entirely conscious cognitive reason. I want to do this, or I'm willing to do this because it would be fun. I'll enjoy it once I get involved. My partner keeps asking me and I want them to stop asking me. So there can be good reasons and not so good reasons, which we'll talk about more on our upcoming slides. But that provided we say, okay, I'm willing, I'm ready, then we engage in some sexual context, there's stimuli, and that we pay attention to that, and that allows and facilitates arousal to happen. And that once we become aroused, we experience something called responsive desire. So it's not desire that comes out of nowhere, hitting you like a lightning bolt. It's desire that says, you know what, this is kind of nice. I like this. I could keep going. And that is actually a common experience for people. And it doesn't mean there's anything wrong with you. It's two different kinds of desire. We've got our spontaneous desire, we've got our responsive desire. And that following that encounter, hopefully we're left with some emotional and physical satisfaction, which will further feed into our motivation to be sexual in the future. So two things I want to highlight from this model are that our motivators, or our reasons for sex, are extremely important, and that we can have responsive desire, and that's also completely normal and healthy and good. So when we differentiate between spontaneous and responsive desire, that spontaneous desire is what we've been told in our social culture environment is the best kind or the only kind of desire. So I can't tell you how many women come to me and say, I have low desire or I have no desire, but who tell me once they get involved, they actually really enjoy sex and that they enjoy it. They desire it once it's happening. And that's because they have more of a responsive system. And that is more common in longer term relationships and as we age. And so I'd like you to think about that spontaneous desire as being this lightning bolt. Who knows if it's ever going to happen? And responsive desire as being more like a spark. So it's a spark that can pop out of a fire and you can do with it what you will. If you've conditioned yourself to, oh, sex is too much work, I don't have time, oh, my partner keeps bothering me, chances are your reaction to that spark is to stomp it out. But if you notice the spark and you go, oh, there's a little bit of desire, let me see if I can work with it and make that stronger, that you'll have a lot more autonomy and control over actually eliciting desire. So it's something that you can actually influence and change. And it comes from a sexual context. So if that's the only thing you take home from today's presentation, that's a massive game changer with your patients. There is nothing wrong with them if their system is more responsive based. So that's an example of some of the kinds of information that can be really helpful to share with patients for limited information. I want you to keep in mind as well that there are some things you may want to supplement with. So helping them to think about how potential changes could be impactful to them. So if you're seeing them before treatment or before childbirth or before menopause, asking them, how do you think this might change things? And getting them to do a bit of planning proactively. If you can provide written information, video links, online resources, it's a lot to retain and it needs to be heard many, many times. So giving them places to go to continue to encourage their knowledge consumption. Encouraging communication outside the bedroom. So often people wait until something bad happens or feelings are hurt, there's a misunderstanding, and they try to figure it out then. But the more couples can actually talk like at the kitchen table before and in non-sexual context, the better. Follow-up is essential. So just doing, one intervention is not going to be enough. Each visit saying, how did that go last time we talked about this? And encouraging and providing reinforcement will be really important. So as I mentioned, I would hope that everyone has some pretty good proficiency as you keep educating yourselves around permission and around limited intervention or limited information. If you're someone who goes, yeah, you know what, the sexuality stuff, it's intriguing to me, I want to learn more, or I have lots of patients who keep coming to me with these concerns, then maybe, looking into more adequate training around specific suggestions is where you want to go next. So we know that there are an abundance of treatment options that can be introduced for pain and for discomfort and desire problems and that kind of thing. So here's a few examples of some of those kinds of products. Encouraging the use of lubricants, using vaginal moisturizers or topical estrogen to help rejuvenate vaginal tissues. Vaginal dilation being an important component for many people with pelvic pain. Use of toys or what I call sexual enhancers to help facilitate sensation and pleasure. And then this is another product, if you haven't seen it, is for collision dyspareunia or pain related to depth of insertion with penile vaginal intercourse. So this is placed over the penis to help decrease the length of the penis and to decrease that collision pain. So you might encourage patients, if you even know that these exist, hey, I heard about this awesome product, go check it out or go talk to a provider who knows more about it. Or you maybe get the expertise to introduce those yourselves. And if you are in that camp where you're wanting to learn more about specific suggestions or you've got really, a good understanding of some of them, what I've done is kind of taken this list of common concerns and linked them to some of the treatments. So we know lubricants, moisturizers, and estrogen can be helpful for dryness and tightness. I do want to differentiate between lubricants that they are helpful to reduce friction during sexual activities or even activities of daily living. So bicycling, riding horses, running, but they're not actually going to do anything to restore tissue health So moisturizers or estrogens can be used to help make those tissues healthier, plumper, more moist, but they need to be used regularly. So every couple days, whereas lubricants are used just when you are trying to avoid discomfort from whatever activity you're engaging in. And most people don't understand the difference between that. Can't tell you how many women I've had who come to me and say, oh, I tried that moisturizer, and they either used it like a lubricant or they used it once and they thought that was enough, but they do need sustained use. Often there's not much impact, less than a month into treatment, and may even need 2-3 months to get a full effect. For painful intercourse, including tightness, or for difficulties related to sensation, vaginal dilation and pelvic floor physio, as well as estrogen, can be helpful. For some of these other concerns related to desire, avoidance or fear, even communication around what people are enjoying in terms of sensation and eliciting pleasure, there are more kind of counseling based resources. So encouraging people to change the kinds of practices they're engaged in. If it doesn't feel good, if it hurts, don't do it, right? And so I have this conversation with people all the time who say, well, I can't have intercourse. And maybe it's taking intercourse off the table and focusing on some of the other ways that people can continue to enjoy a sexual relationship, that they feel empowered and they feel safe and comfort. So alternative practices, changing what you're doing in terms of that sexual script or dynamic. Education about sexual response and desire. So I didn't go into that whole model today, but I gave you 2 really helpful things that you can have a brief discussion with patients about. What are your motivators? And what's the difference between responsive and spontaneous desire? And I'm actually going to talk about motivators a little bit more on my next slide. And then lastly, communication. I love using mindfulness meditation with my clients, helping them to get more aware of what's happening in the moment, and being less judgmental and more accepting of what's going on. So if you're paying attention, but the whole time you're going, oh, this is so uncomfortable, or I can't believe my partner's doing this, or whatever, fill in the blank, you're not going to enjoy your experience. Whereas if you can really pay attention to body sensation and let go of some of that judgment, it's going to enhance your sexual experience. And then for more relationship or safety in terms of engaging in sexual experiences following fear or avoidance, sensate focus is an excellent practice that couples therapists and sex therapists can guide patients through, which is a structured way of reintroducing touch within relationships. So as I mentioned, this model, fabulous for a lot of reasons, but 2 really important take-home messages are your motivators and responsive desire. So let's briefly talk about motivators. We know that there are a lot of different reasons why we might choose to engage in sex, and a study done by Cindy Maston showed 237 unique reasons for why participants indicated they had last had their most recent sexual encounter. I will acknowledge this is a sample of college undergrads, but still, it suggests there's a lot of different motivators. And their team categorizes these into a few categories. Physical motivators, including stress reduction, pleasure, desirability, etc. Goal attainment, so attaining resources, having a social status improvement, getting revenge on a partner. Emotional, which is love, commitment, expression, or closeness. And insecure based reasons, so needing a self-esteem boost, feeling pressure from a partner, or wanting to preserve your relationship or guard your mate from being stolen by somebody else. So you might encourage patients, or even if this could be helpful for yourself, to think about what are your reasons to have sex? Is it just because you feel horny and interested? Or are there a lot of other good reasons? Now, some of those reasons may be negatively valenced. What these are referred to are avoidance reasons. Reasons, for example, that you engage because you want a negative feeling to go away. Guilt, fear, obligation. Can't get my partner to stop bothering me till I say yes. Those reasons are not innate for you to be able to gain something good. They're trying to get rid of something negative. And avoidance reasons undermine sexual desire. The more you engage because you feel like you're a bad partner if you don't, or you feel that you're worried your partner will get a wandering eye and start looking elsewhere, they will undermine your own desire. Whereas reasons that are positive or rewards based are things that you stand to gain by engaging. For example, a sense of feeling close to one's partner, feeling sensations of pleasure, wanting to have a physical release or wanting to sleep better, feeling attractive or desirable. These are all things that you stand to gain rewards. And so, what I might offer is that sometimes low desire in the context of bad sex is common sense. No wonder we don't want to have more sex if that sex isn't very good and we're not getting very much out of it. So the more that we can shift to rewards-based reasons, and the more that we can make sex more rewarding, the more reinforcing that will be of desire. So if you only have a few minutes with your patients, you might even just ask them to think about, what are your reasons? Hey, did you know that if you actually get more rewards, you'll be more motivated? Right? What do you think some of those rewards could be? That might be a 1-minute conversation that you have with your clients or patients. So lastly, just to quickly give an indication of when intensive therapy is appropriate, studies demonstrate that referral to experts or intensive therapy usually is only needed in about 20% of cases. That specific suggestions can often help most of the population. So if you're looking at who to refer to, here's a list of practitioners that can be really helpful. Again, they've likely identified that they have some kind of expertise or training in sexuality, and that could be physicians or nurse practitioners, as well as people who've identified as being specialists more in the area, and that can be sexual medicine specialists that are family physicians or associates, as well as urologists and gynecologists. There are lots of folks out there who identify as sex therapists, and they may or may not be quality trained. So usually looking for someone who has either an ASEX certification or a PhD or advanced level training, master's in sexual health, can be a helpful way of differentiating between practitioners with quality expertise versus, these days, anyone can call themselves a coach. So kind of differentiating between quality service there. Also recognizing that whether the specialist is sexuality based or not, you may have people who have trauma history, who have trauma related to sexual abuse or assault or birth trauma. And so referral for trauma can also be really helpful, even if it's not related to current sexual function. Pelvic floor physiotherapy, cannot praise them enough for the fabulous work they do in the area of sexual health, as well as educators and occupational therapists that have identified they have expertise in sexuality. So when do you know when to refer? I think it's important always that we're reflecting on what are the limitations of our capacity. Even hanging my expertise in this area, I still come up against things where I need to refer and consult and all of those important things. So recognizing that your limitations could be maybe at limited information and you need to refer out for simple suggestions. Or maybe you feel pretty confident about simple suggestions and you need to refer out at the intensive therapy level. So recognizing where do you feel comfortable and where do you feel a little bit maybe in deep water. I also find that multidisciplinary approaches are extremely helpful, especially if there's a complexity here, whether that's a medical situation or longstanding history of sexual dysfunction, poor coping in general, mental health concerns, or abuse and trauma history. So I find that these kind of more complex cases, we often need 3 or 4 providers helping support patients, especially as well if they're primarily relationship issues. Treating the sexual component or the functional component isn't likely to have a huge impact if the relationship's actually the primary concern. And another consideration is compliance. When patients, you've given them those simple suggestions, but they're not following through. They're not using their dilator, they're not using their moisturizer, that often they may need some psychology support around behavioral change and motivation. So those are some considerations for when to refer. So just before I take some questions, I just want to acknowledge a few other sources of information. I'm on Instagram, and my mission there is to really translate what we know from science into day-to-day messages to help people engage with behavior change. So I'm always making posts there. Please send people to that if that's a good source for them. Many of the toys and products that I mentioned on that slide for simple suggestions, I actually have compiled into something called Dr. Walker's Toy Box, which is a collaborative with Sensual, a local small sex toy company. I do not make any money off of this. It's just a convenient place for me to say, go to the toy box, it's in there, instead of sending people a bunch of links. And then I do want to let you know about an ongoing workshop series that I'm offering in collaboration with a local medical clinic called MOD. And so this is our poster advertising our workshops. And this is the first in a series. So there will be subsequent, more specific workshops, like one on low desire, one on pain, for example. But this one's sort of an intro. People can get a taste of what it's like and what I'm like and learn a little bit more information. So these will be offered regularly. And we do also have some compassionate fee waiving for some folks who can't afford to register. But that will be on kind of a waitlist basis as those seats fill. So please do consider sending this information out to any patients that you have or friends that you think might be interested. And I'll just go back to questions, and then we can open that up for questions.
All right, thank you so much, Dr. Walker. That was an excellent talk. I've got a couple of questions in the sort of anonymous chat box, but first I'm going to pause our recording so that we can start getting into the questions.